ultrasound, guided pudendal nerve block. Pudendal nerve blocks have a wide range of clinical applications for the management of acute postoperative pain in urologic, gynecological surgery, in coloproctology, as well as in pain medicine for differential diagnosis and for the management of pudendal neuropathies. However, despite its benefits, it is infrequently used. Anatomy of pudendal nerve. The pelvis is made up of three bones called ilium, ischium, and pubis. To understand the anatomy and root of the pudendal nerve, we must take into account a series of bone structures that will guide us throughout its approach. The ilium, ischium, and sacral bones, the greater sciatic foramen, sciatic spine, and ischial tuberosity. Pudendal nerve is the main nerve of the perineum. It is a pair nerve that carries sensation from the external genitals of both sexes and the skin around the anus and perineum, as well the motor supply to various pelvic muscles. The pudendal nerve is formed by the ventral rami of the second, third, and fourth sacral spinal nerves, with the primary contribution coming from the fourth. After its formation, the pudendal nerve descends and leaves the pelvis through the lower part of the greater sciatic foramen. Once the nerve exits the pelvis, inferior to the piriformis muscle, it courses for a very short distance within the gluteal region, where it bends around the dorsal aspect of the sacrospinous ligament and ventral to the sacrotuberous ligament to enter the perineum through the lesser sciatic foramen in close relation with the obturator internus muscle. The nerve enters the perineum through the pudendal canal, also known as Alcock's canal. This canal is a fibrous tunnel formed by the fascia of the obturator internus muscle. The internal pudendal artery and vein are also found along the course of the pudendal nerve and its branches. At the gluteal level, the internal pudendal artery was found lateral to the nerves in 60% of cases, medial in 35%, and on either side of the nerves, double, and slightly lateral and ventral to them in 5% of cases. Inside the pudendal canal, the nerve divides into three branches: the inferior rectal nerve, the perineal nerve, and dorsal nerve of the penis or clitoris. The pudendal nerve supplies sensation to external genitals of both sexes and the skin around the anus, anal canal, and perineum through its branches. The inferior rectal nerve innervates the perianal skin and the lower third of the anal canal, provides motor supply to the external anal sphincter. Therefore, the pudendal nerve provides the voluntary somatic control of fecal and urinary continence. The perineal nerve innervates the skin of the perineum, labia minora and majora, or posterior scrotum, muscles of the perineum and pelvic floor, and the external urethral sphincter. The dorsal nerve of the penis or clitoris innervates the skin of the penis or clitoris. They are responsible for the afferent component of penile and clitoral erection. Sonography. Among the anatomical references that we should remember when carrying out the ultrasound examination of the pudendal nerve, the most relevant are the ischium and sciatic spine, the sciatic nerve and the inferior gluteal artery, the internal obturator muscle, and the pudendal artery accompany the nerve throughout its course to the genital area. For a proper ultrasound scan of the pudendal nerve, it is essential to know certain key bone reliefs, which will allow us to guide our approach. Once we know the exact point of the nerve's path, thanks to these bony projections, we will use the pulse of the internal pudendal artery to direct our needle to its proximity. The pudendal nerve is usually not visible with ultrasound. The transducer must be placed in an axial plane, scanning at the level of the posterior iliac spine, lateral to it, and over the ilium. The ilium is identified as a diagonal hyperechoic line that crosses the screen from side to side. In its superficial part, we will observe the presence of the gluteus maximus, medius, and minimus muscles. When sliding the transducer in a caudal direction, an acoustic gap will appear, breaking the acoustic shadow generated by the ilium. This gap corresponds to the greater sciatic foramen, where the internal pudendal, superior and inferior gluteal vessels, and all the branches that form the sacral plexus emerge. All these structures courses over the ischium during its descending path. The ischial spine must be recognized as a straight hyperechoic line with the acoustic shadow deep to it. The sacrospinous ligament as a continuation of the hyperechoic line of the ischial spine. of lower echogenicity than the bone, the sacrotuberous ligament, superficial and parallel to the sacrospinous ligament, deep to the gluteus maximus. Laterally, it is crucial to recognize the superior gemellus muscle, the sciatic nerve, and the inferior gluteal artery. With the transducer in this position, on the medial edge of the image, attention must be focused on the identification of the internal pudendal artery and the pudendal nerve, the latter being difficult to visualize because of its small size. At the level of the ischiatic tuberosity, the sciatic nerve is already located between the tuberosity and the femur trochanter. The pudendal nerve and artery are found within Alcock's canal over the obturator internal muscle to re-enter into the perineum. Bony shape plays a key role in the ultrasound examination of the pudendal nerve. A diagonal line crossing the screen from side to side has to make us think about the ilium. The acoustic gap between the sacral and iliac ridge corresponds to the greater sciatic foramen. A straight hyperechoic line with the acoustic shadow deep to it corresponds to the sciatic spine. The ischiatic tuberosity is identified as a rounded hyperechoic line covered by a thin hypoechoic lamina that corresponds to the obturator internus muscle. Once we are able to orient ourselves, guided by the acoustic shadows generated by the bone projections of the pelvis, we will go in search of our target, the pudendal nerve. For this, we will help us from the pulse of the inferior gluteal and internal pudendal artery. Given the reduced size of the nerve, it is not possible to identify on most occasions. To identify vascular structures, specifically the inferior gluteal and the internal pudendal arteries, color Doppler imaging is recommended. By moving the transducer in the caudal direction, we will observe the separation of the pudendal artery in the medial direction at the level of the ischial spine. A few centimeters below, the artery enters Alcock's canal over the obturator internus muscle, taking an anterior course to reach the perineum. Pudendal nerve blocks may be performed through two approaches, anterior perineal or posterior transgluteal. The perineal approach is used for distal entrapments or for anesthetic analgesic purposes. The posterior approach has been used in recent years in proximal nerve entrapment syndrome, with a high rate of success in terms of the diagnostic therapeutic objective, although with a moderate 21.7% risk of sacral plexus blockade. With the patient in a prone position, and once all the key structures have been recognized, the transducer should be moved at the same angle until the pudendal neurovascular bundle appears in the center of the ultrasound image, over the sciatic spine and under the sacrospinous ligament. This is where the puncture will be made either in plane from medial to lateral or out of plane. Sensory or motor neurostimulation may be used in the proximity of the nerve in order to determine the presence of paresthesia or motor contraction in the territory of the pudendal nerve. Fitchner suggests a slightly more caudal technique at the entry point to Alcock's canal in order to reduce the risk of a sciatic nerve block. This approach targets the pudendal nerve inside the Alcock's canal by following the margin of the hip bone sonographically along the greater sciatic notch, the ischial spine, and the lesser sciatic notch. The use of color Doppler is advisable to identify the internal pudendal artery above the internal obturator muscle. The approach will be performed in plane, from medial to lateral or out of plane. Same as any pudendal approach, nerve stimulation is advisable to confirm sensitive or motor response. For chronic pain, a mix of long-acting local anesthetic and steroid is used in a volume ranging from 4 to 6 cc's. When it is performed as an anesthetic or analgesic technique, the same volume will be administered, but using a short-acting or long-acting local anesthetics depending on the purpose. Thank you for your attention. I hope this video has cleared some of the doubts that currently exist regarding the pudendal nerve block. A block that can be very useful in gynecological and proctology surgery and to treat pudendal neuropathy, a very prevalent pathology nowadays. See you at the next Ezra meeting.